Welcome everyone to this webinar hosted by the Fujita Bantane Alumni Association, and thanks to the Asian Congress for giving us this possibility once more, as we do every month. Today we have 3 speakers with very interesting topics, but before starting, let me thank my co-moderator, Professor Ishu Bishnoi, and also our commentator today, Professor Raja Krishnankuti. Also, we have our discussants, and I want to thank them all. Before introducing the first speaker, I kindly ask Professor Yoko Kato, our leader and mentor, to spend a few words to introduce this webinar today. Thank you, Professor Kato.
Thank you so much. So I hope that everyone is in good condition, even this wartime. So I think today's the 3 speakers, I'm proud of them. So especially the Akutsu sensei is one of the best lesions the speakers. So I think we can start now. Thank you.
Thank you, Professor Kato. So it's my pleasure to introduce our first speaker, Professor Hiroyoshi Akutsu. Professor Akutsu is professor and chairman at the Department of Neurosurgery at Tokyo Medical University. He had his training in Japan, but also abroad. In particular, he has been a clinical fellow in Germany from 2005 and 2007. He has some specific areas of interest, in particular endoscopic endonasal surgery, skull base surgery, pituitary and skull base tumors, neuroendocrine and neuroimaging. He has been author of more than 130 peer-reviewed articles published on PubMed, and also of 25 book chapters. Today he will talk about endoscopic endonasal surgery for skull base tumors. So thank you, Professor Akutsu, and you can start sharing your screen.
Okay, thank you, Professor Felletti, for kind introduction of me. And it is a very honor to have a chance to talk today. And so I will share the slide.
Yes, we can. Thank you.
So today I will talk about endoscopic endonasal surgery for skull base tumors. I hope it is interesting for not only the young neurosurgeon, but also the expert neurosurgeons. And this is my personal experience of endoscopic endonasal surgery in my department, and also in my last institutions. So as you can see, I have experienced 1,069 surgery for various type of skull base tumors. And most of the cases were pituitary and neuroendocrine tumors. But now recent years, the various type of skull base tumors can be the candidate of the endoscopic endonasal surgery. And most important concept of endoscopic endonasal surgery is creating wide working corridor, because in the narrow working corridor, there is some conflicts between the endoscope and the instrument, like in this figure. But if you create a wide working corridor, this instrument and the endoscope can be a wide distance, that makes the comfortable instrumentation during surgery. This is one surgical tip of superior maximization of anterior sphenoidotomy, which is a very important procedure to create working corridor. But we have to pay attention to the olfactory function, and we are doing this procedure. Firstly, we elevate the olfactory mucosa from the nasal septum to the anterior skull base. Then after that, we remove the upper part of the anterior sphenoidal sinus, and then we can create a wide working corridor with good visualization to the anterior skull base, with preserving the olfactory mucosa. And we reported the olfactory function before and after surgery in cases of craniopharyngioma and meningiomas. As you can see, only about 10% of the patients had olfactory disturbance after surgery, and we have no anosmia after surgery, which is much better than the reported result, which is about 20% of the anosmia was reported after the endoscopic endonasal surgery for meningioma in the reported cases. And another important tips of endoscopic endonasal surgery is reliable cranial base reconstruction. We are using suturing technique of the dura after surgery, and with it tailored to the CSF leak grade. If there is a low flow CSF leakage, typically in cases of pituitary neuroendocrine tumor, we are using fat graft or then the dural suturing covered with sphenoidal sinus mucosal flap. And now we are using the Duragen or gelatin matrix, not using the oat graft to minimize invasiveness. And in case of the high flow CSF leakage, typically in cases of craniopharyngioma or meningioma cases, we use a facial lata graft or inlay and overlay with suturing technique like in this picture. And now we are using also French door dural closure method, which is closing the dura to reinforce facial lata graft, which is also very useful technique, and with using the nasal septal flap and the dural sealant. And nowadays, so we don't use nasal septal flap, but sphenoid sinus mucosal flap to minimize invasiveness to the patient. And we are only in high-risk cases, we use a nasal septal flap right now. And we don't use a hard buttress or no prophylactic spinal drainage. So I will show you some clinical cases, which is a 54 years old patient with craniopharyngiomas. MRI showed a very large cystic suprasellar craniopharyngioma, like this. And in this case, we use an endoscopic endonasal approach. And I will show you the movie. This is after superior maximization of the anterior sphenoidotomy. With using this technique, you can have a good visualization of anterior skull base. And after dural opening, and then the cystic wall is removed, dissected from the frontal lobe and optic nerve. Also from the branch and of the anterior cerebral artery. And after dissecting the cystic wall, you can see here the pituitary stalk is invaded by the tumor. So we cut the tumor, then I dissected the tumor from the pituitary stalk with subpial dissection technique. And you can see all the tumor is resected. And with using ICG, the perforating artery is patent. And after that, the cranial base reconstruction with suturing, then covered with sphenoidosal mucosal flap. After surgery, the MRI shows a nice resection of the tumor, and the patient visual function improved, and endocrinological function is partly preserved after surgery. We have just published technical nuance of this subpial dissection technique in the Surgical Neurology International. And now I show you the approach selection for craniopharyngioma of 110 cases of treated cases in our institution. As you can see, the number of endonasal approach and transcranial approach. At the beginning of the surgery, so we use both approach to about similar cases. After that, the number of the endonasal surgery is increasing over time. And recent 5 years, we use only endonasal approach for any type of craniopharyngiomas. And also we have published a result of the endocrinological function after surgery in cases of pediatric craniopharyngioma. And as a result, the gross total resection was achieved in 85.7% of the patient in 22 pediatric patients. And as you can see, over half of the patients, we could preserve some endocrine function after surgery. And especially in cases of infradiaphragmatic tumor, the endocrine function could be preserved. And but we have to pay attention to the recurrence after surgery, and because this result showing that in cases of morphological preservation of the pituitary stalk, the recurrence rate is higher than the other cases of sacrifice or already lost of pituitary stalk. So whether the pituitary stalk is preserved or not should be judged by the clinical condition of the patient. Now I move to the meningioma cases. The selection of the surgical approach for the tuberculum or planum sphenoidal meningioma is now still in matter of debate. And in our institution, the endoscopic endonasal approach is a first-line approach for small or meningioma centered on the tuberculum sella, like in these MR pictures. On the other hand, the transcranial approach should be selected for a large tumor, which is about 35 millimeter in maximum diameter, and the tumor centered on the planum sphenoidale, or tumor with lateral or anterior extension, or the pial blood supply with having brain edema, like this patient, or also the vascular encasement, like this figure, that the transcranial approach should be selected. So I will show you the good indication of the endoscopic endonasal approach for tuberculum sella meningioma. This is a case of 60 years female patient who had a visual impairment, and the MRI showed a relatively small tumor without marked lateral or anterior extension. And also, you can see the cell floor is much lower than the anterior skull base. This is a very good indication for the endonasal approach. I will show the movie. After drilling the anterior skull base and also medial optic carotid recess, then you can see the wide exposure of the anterior skull base dura. And after that, the dural incision in a midline, and anterior intercavernous sinus, it's stopped with a flow seal injection into the sinus. Then after that, cut the anterior intercavernous sinus, and the dural margin is attached with the fibrin glue. And as you can see, in this case, the tumor is very hard, and so the surrounding structure is dissected. After that, the internal debulking with QSA is performed. Then you can see here the branch of the superior hypophyseal artery, which should be preserved to maintain the optic visual function after surgery. And then the sharp dissection, and after that, internal debulking again. So you can see the all around the tumor can be dissected from the neurovascular structure. Then the tumor is totally resected. Here you can see the pituitary stalk is compressed by the tumor, and all the perforating artery could be preserved. After that, cranial base reconstruction with suturing technique, then overlay facial lateral graft. So after that, sphenoid sinus mucosal flap is applied, then fixed with a dural sealant. And after surgery, you can see the nice resection of the tumor, and visual function improved after surgery. We have also just published the technical nuance in cases of tuberculosis meningioma, and we have stressed the importance of the resection of the superior wall of the optic canal. Like this picture, this procedure make it easier to resection of the tumor of the in case of the tuberculosis meningiomas. Now I move to the clival chordoma, which is also the challenging entity of the in the skull base tumors. In this case, the patient had bilateral 6th and 3rd cranial nerve palsy, and also the visual disturbance before surgery. And MRI showed the tumor arising from superior part of the clivus, and also tumor extending into the intradural space. And in this case, we have expected some adhesion between the tumor and ventral brain stem. And so I will show you the movie. So to making a working space, we have ethmoidectomy, so bilaterally to make space. And then the rhinopharyngeal mucosas dissected from inferior wall of the sphenoid sinus. Then the entire clival bone is removed with drill, including the bilateral carotid protuberance like this. And after that, the tumor is piece by piece resected. And in this case, the tumor is invading in the intradural space, so the dura should be resected like this. And then here you can see the abducens nerve of the in the left side, and the bilateral posterior clinoid process is removed like this. And here is a opened cavernous sinus, and you can see the carotid artery on the left side. And after that, the intradural tumor is dissected from neurovascular structure, and partly the arachnoid membrane is preserved. So I use this arachnoid to preserve the intradural structure. Then here you can see the abducens nerve on the right side. The tumor is resected, and here you can see the perforating artery from a basilar artery. Fortunately, in this case, the tumor could be dissected from a brainstem. And finally, the tumor could be resected in total. It's preserving the higher membrane of the brainstem. And ICG showed a good flow of a perforating artery from a basilar artery. And here you can see a very big dural defect. So I make a suturing the facial lateral graft to the dural edge like this. So, and there is some more stitch on the dural edge, and facial lateral graft should be inlay that makes reliable closure, and also the dural itself was also sutured. After that, the fat graft is put it on. Then the nasal septal flap is used in this case, because in case of the chordoma case, we have proton beam radiotherapy. So I used nasal septal flap routinely. So after surgery, you can see a good total resection of the tumor. And after surgery, the cranial nerve palsy resolved. And after that, we send the proton beam facilitation to have a irradiation. But we have to pay attention to the recurrence after surgery in cases of chordoma. This is a published data from our institution. We have 83 chordoma cases, and there have all the patients had adjuvant proton beam therapy. But even after proton beam therapy, the 5-year local recurrence occurred 44% of the patient, which is not satisfactory in our series. And but in cases of the chondrosarcoma, the 5-year local recurrence occurred only in 7.1%. So the chordoma is still challenging with using proton beam. And the factor for local recurrence in chordoma was tumor maximum diameter over 30 millimeters. So the big tumor should be care for local recurrence even after proton beam irradiation. And I talk about the complication of endoscopic endonasal surgery. The CSF leak rate was 3.0% in our series, which is much better than the published literature in the other institution. And also, the only 1.8% of the patient need revision surgery after CSF leakage. And the vascular injury is for 0.4%. And and the mortality rate was 0.2%, which is competent to the published series. So in conclusion, the creating a wide working corridor is crucial for comfortable instrumentation. And a cranial-based reconstruction with dural suturing tailored to intraoperative CSF leak grade is useful to prevent postoperative CSF leakage. Thank you for your attention.
Thank you very much, Professor Akutsu, for this wonderful presentation. We can now start the discussion, so I kindly ask our commentator today, Raja, to give his comments and questions. Thank you, Raja.
Thank you, Alberto, for inviting me. Professor Akutsu has given a beautiful demonstration of varied pathologies for skull base, and he has shown how a wide spheroidectomy can result in better resection. I would like to ask that how do you plan, what is your standard procedure of closure for to obliterate the dead space after surgery? Do you put a lot of fat graft in it?
Okay, thank you. In cases of craniopharyngioma or meningioma, like anterior skull base lesions, I don't use a fat graft because there is no dead space. But in cases of chordoma or chondrosarcoma, which is an clival lesion, in that case, I don't use every cases for the fat graft, but in some case I use a fat graft put on the facial ladder graft to obliterate the dead space between the nasal septal flap and the dural layer. But it is not all cases, but in some cases I use it.
So you prefer it to choose case by case?
Yes.
Right. Thank you very much. And in all these cases of doing extended endoscopic skull approaches, do you use a pre-operative lumbar drain? And till how many days do you keep it, if at all?
Okay, thank you. Good question. I only use prophylactic lumbar drainage in cases of chordoma or chondrosarcoma. This is a posterior fossa tumor because risk of CSF leak is higher than the tumor in the other anterior or middle skull base lesions. So only in cases of the high risk case, so I use a prophylactic lumbar drainage.
So for a normal pit net, you do not use lumbar drain?
I don't use it.
Okay, that's really surprising. Thank you very much.
Thank you.
Ms. Alberto?
Thank you, Raja, and we can keep the discussion if there are other questions from our discussants. I think Thomas is connected, but he's texting me. Oh, he is trying to connect. Okay, he is on his road. But I have a question. Oh, hey, Thomas. Hi.
So sorry, I cannot on the cam because I'm still on the road.
Yeah. No problem. Safe drive.
Okay.
Okay, I want to ask Professor Akutsu one question. You have shown us that the rate of endoscopic endonasal surgeries at your department basically replaced other approaches. However, there are some cases when the tumor is very extended laterally. Recently, I had a case of a pitnet with a Sylvian fissure extension, or sometimes, not so frequently, but sometimes the tumor goes beyond the dorsum sellae. So how do you manage those cases? Do you keep the endonasal endoscopic way as your first choice, and then eventually you make a second look through another route, or do you consider craniotomy in those very specific cases?
Thank you. In case of a pituitary neuroendocrine tumor, if the tumor extended so the laterally or superiorly, in some huge tumors, it is very difficult to manage only using endonasal approach. So in that case, I use a combined and transcranial and endonasal approach because I don't want to have a postoperative hematoma from a residual tumor. But in case of craniopharyngioma, I can only use endoscopic endonasal approach in most cases because there is very little risk of postoperative hemorrhage. We can use some staged surgery if there is some tumor remnant after surgery. And in cases of meningioma, this is very difficult to select approach. In case half of the anterior skull base meningioma, I use only transcranial approach, and especially in cases of very big tumor. In that case, so I prefer to use a transcranial. So the indication is depends on the tumor histology and also tumor extension. And so, thank you for this question.
Yeah. Thank you for your answer. I think you made a very, very important point about the risk of hemorrhage. I totally agree with the pitnet. We know if we leave a remnant behind, the risk of hemorrhage, postoperative hemorrhage, is higher than other tumors. So I totally agree. Thank you. It's very important for young neurosurgeons to know this, I think. Thank you so much.
Can I ask one more to Prof?
Yes,
Akutsu?
Raja. Of course, you are the commentator, so you have the right.
Nothing, just I would like to ask him that, do you still operate on papillary craniopharyngiomas in your place? Because the recent discovery of the tumor shrinkage control rate up to 90% for BRAF V600E mutations when patients are given vemurafenib. So most of the places have opted for this treatment rather than operative intervention. How is it in your place?
You asking the in case of craniopharyngioma?
Yes, papillary type.
Which type?
Papillary.
Papillary type. Okay. Papillary type. Yes. Yeah. In papillary craniopharyngioma, the most of the case arising in the third ventricle, and in that case, it is sometimes difficult to decide that if the tumor is located only in the purely in the third ventricle, or there is some portion extruding from third ventricle to the pituitary stalk. Now, if there is some tumor part extruded from a third ventricle to the pituitary stalk, then I select the endonasal approach. But if the tumor is purely in the third ventricle, in that case, the transcranial approach is better than the endonasal route.
But do you consider immunotherapy?
Immunotherapy. So,
BRAF V600E mutations.
okay. Yeah. There is some alternative of
Vemurafenib.
targeted chemotherapy. Yes. But so in my experience, the most of the papillary craniopharyngioma can be controlled with radiotherapy. So the I don't I haven't not yet have a experience of that medical therapy for papillary craniopharyngiomas. So because the control rate of the radiation therapy is better in case of the papillary craniopharyngioma than the adamantinomatous craniopharyngiomas. But there is a so one alternative of the treatment, I think.
Okay, thank you.
I have one question. Yeah.
Sì, sure.
Yes.
Yeah, thank you, Professor Akutsu, for such a wonderful lecture and wonderful videos. My question is about hormone secreting pituitary tumor, not large, simple macroadenomas. How do you confirm complete removal of tumor after surgery? Like, how do you know that the tumor has been completely removed? Because even a small residue can cause recurrence of the symptoms because of high hormone, especially in acromegaly cases.
Yeah, thank you. So the in case of microadenoma, it is not difficult to make sure the complete removal of the tumor. But as you say, the macroadenoma, in some cases, it is difficult to determine if there is an invasion into the cavernous sinus or not. So if there is some possibility to have an invasion into the cavernous sinus, then I will take out the medial wall of cavernous sinus for secure the removal. But in most of the case, I can judge if there is a invasion or not. And if there is some invasion, the medial surface of medial wall of the cavernous sinus is a little bit so irregular or thickened. So in that case, I take out the medial wall, but not then I don't open the medial wall of the cavernous sinus. So I don't aggressively resect the medial wall of the cavernous sinus in only in selected case, and if I judge the some invasion in the wall, then I take out the medial wall after resection of the main tumor.
Okay, and do you cut the stalk, like if the patient is presenting second time with the recurrence in hormone secreting adenomas? So do you prefer to cut the stalk or again try to preserve it?
Pituitary stalk, do you mean?
Yeah.
In cases of acromegaly?
Yeah, and with recurrence, because I have seen that they develop cardiac side effect, cardiomegaly, and they become very unfit for the recurrent surgery because of the dilated cardiomyopathy.
I don't have no experience of the tumor invading into the pituitary stalk in case of the pituitary adenoma. So I don't have.
Not invading the pituitary stalk, like just to be sure that the hormone becomes normal, uh, so that the third surgery will not be considered. For that, do you try to cut the stalk or?
No, I don't cut the stalk. So in case of pituitary adenoma, I don't think that it's necessary for the pituitary adenoma.
Okay, thank you, Professor. And one thing, how do you cut the medial wall of the cavernous sinus? Like, how do you cut it?
How I cut? I begin to cut from inferior edge of the medial surface, and because of the medial wall, because at this area the distance, there is a distance from carotid artery to the medial wall. So here I begin to cut, and then after that I carefully remove the medial wall to upper part of the wall.
Thank you, Professor.
Thank you.
Thank you. We have a couple of questions from the audience. I will read them. So the first case you presented with craniopharyngioma who had total excision. How was the postoperative condition of the patient, considering the tumor appears to have invaded the hypothalamus and frontal lobe? This is the first question. And the other question is, thank you for a wonderful lecture. Have you had patients who had visual deterioration postoperatively? What was the cause of visual deterioration? How did you manage the patient visual deterioration?
Okay, and for the first question, the huge craniopharyngioma case, after surgery, the patient has no disturbance of the hypothalamus, so he returned to the work, and also visual symptom improved after surgery, and in terms of the endocrinological function, the diabetes insipidus occurred, but the pituitary function is partly preserved. Only the growth hormone disturbed, but other cortisol or thyroid function could be preserved. And the second question is in terms of visual dysfunction. I don't follow this visual dysfunction after surgery for pituitary tumor, or which tumor? I didn't hear that. Visual dysfunction after.
Yeah. After surgery, in general, he's asking after.
In general.
Yeah, if you had some complications related to visual impairment after surgery.
Yeah, especially in cases of meningioma case, there is some visual worsening after surgery. In that case, most of the case was vascular ischemia of optic nerve. Even after preserving the superior hypophyseal artery, in some case, maybe because of the vasospasm or something, the patient will have a visual worsening after surgery. And also, if the tumor is very hard or severe adhesion of the tumor with a visual apparatus, in that case also there is some not many, but some case of visual dysfunction after surgery. And in that case, there is no specific treatment for visual worsening, but I use some steroid treatment. In some cases, there is some effect, but in some cases, no. So it is important not to make some very careful dissection of the perforating artery from the tumor. Is it okay? So
Thank you. Thank you, Professor Akutsu. Thank you so much. And if there are no other questions from discussants or from the floor, I thank you very much, Professor Akutsu, for the wonderful lecture and also for the brilliant discussion after that. And I will now hand over to my co-moderator, Ishu, for the next lectures. Thank you.
Thank you.
Yeah. Thank you, dear Alberto. And I will invite our next speaker, a very young neurosurgeon, Dr. Saurabh Gupta. He is currently working as assistant professor in the ICMR Hospital, Bhopal, in India. And he has done his neurosurgery from Premier Institute, AIMS, New Delhi. And he has been awardee of many international awards. And he has done observership in Skull Base and in microvascular anastomosis. He is a hybrid young neurosurgeon, and today he will be going to give his talk on hemodynamic impact of remnant location after woven endo bridge treatment, a preliminary computational fluid dynamic analysis. So I would like to ask Dr. Saurabh Gupta to present. Yeah.
Thank you for the kind introduction, Professor Bisnoy. Konbanwa, Professor Kato, for allowing. Thank you for giving me the opportunity to present in this Alumni Association webinar. I have changed my topic because the CFD in web-treated aneurysms, the manuscript is still not submitted for publication. So I'll be slightly. Should I share my screen?
Yeah.
Yeah. Are my slides visible?
Yes.
Yeah. So instead of presenting CFD in web-treated aneurysms, I'll be, because it has not been submitted for publication yet, I'll be sharing my presentation on computational fluid dynamic analysis in intracranial aneurysms. So to begin with the background information, the unruptured intracranial aneurysms have a prevalence of 3.2 per 100 population. Because of better screening, it is as high as 7% in China and around 3% in Japan. Exact literature about the prevalence in India is still not known because of the lack of quality studies. Rupture of these aneurysms significantly impacts the life expectancy and the quality of life. Better screening of better availability of better screening methods has led to higher detection and treatment of unruptured intracranial aneurysms. These have a higher incidence amongst advanced age, hypertensive patients, patients with smoking history, alcohol abuse, and atherosclerosis. Regarding the management of unruptured intracranial aneurysms, they are still debated. While observation has been suggested for anterior circulation aneurysms measuring less than 7 millimeters in size, still these days, because of better availability and safer endovascular techniques, 5 millimeter aneurysms are also being treated. Because of the availability of 0.017 microcatheters, even 3 millimeters aneurysms can now be treated. Surgical treatment remains a common practice in our country for simple aneurysms undergoing clipping, while the complex ICA aneurysms undergoing high flow bypasses. Endovascular options include coiling, stent-assisted coiling, flow diverters, and the woven endobridge technology. Web devices are not very common in India. These are intrasaccular flow diverters, which are intended to treat the wide neck aneurysms which cannot be coiled. So coming to the main crux of today's presentation, it's about computational fluid dynamics. This was a new topic for me, which I was exposed to during my fellowship at Fujita Bantane Hospital under the guidance of Professor Yoko Kato. CFD basically uses mathematical equations to assess the hemodynamics within the cerebral aneurysms. All we need is the preoperative imaging data, which could be either be a thin slice CT-NG of 0.5 millimeters or a DSA. It goes beyond conventional imaging. It allows us to quantify the hemodynamic forces that are acting within the aneurysm, about the forces which we'll be discussing in the coming slides. It has multiple applications. These can be used to study the initiation of aneurysmal growth, and the rupture risks. It also helps us in, as per the literature, it helps us in improving the surgical safety. They can help us in identifying the thin-walled regions as well as the parent artery microaneurysms, which are often not seen in the conventional DSA images. Before we proceed to the parameters that are assessed in CFD, I'll just present a brief introduction about how a CFD analysis is done. All we need is a CT angiogram, thin slices as mentioned, 0.5 millimeters, or a 3D DSA, and DICOM processing software in Fujita, we used geostation to separate out the arteries. Like this has to be done according to the vessel. Like for example, for a simple MCA bifurcation aneurysm, all we need to isolate is the ICA, the A1, as well as the MCA and M1 and M2s. For ACOM aneurysms, we need to isolate both the internal carotid arteries, both the A1s and both the M1s. And accordingly, it can be proceeded. After the vessel extraction has been done, the mesh is generated using a hemoscope software. The vessels are labeled and a three-dimensional mesh is generated using center lines and cross sections. The vessels are labeled and the inflow and outflow conditions are defined. Before processing for the analysis, we have to choose between the steady state versus pulsatile flow because we are mimicking the intracranial aneurysms. We have to choose the pulsatile flows because, as we know, systole and diastole have different impact on the blood flow towards an aneurysm. After processing, the scaling is done and images are analyzed. Now, coming to the parameters that we study in computational fluid dynamics, they start with simple streamlines, which measures the direction and blood flow pathways. It also informs us about the velocities and about the parent artery as well as the aneurysm, as well as the direction of the blood flow within the aneurysm. The pressures are identified. This is the wall pressure, which quantifies the perpendicular forces on the wall. Wall shear stress is an important parameter. It measures the frictional force that is exerted by the blood flowing through the vessel lumen and the aneurysm. Apart from being a quantitative direction, so WS's direction is also shown in the computational fluid dynamic analysis. The advanced parameters which can be assessed only in pulsatile flows include two things. Those are the oscillatory shear index and the WSS vector direction variation. Both of these are used to quantify the variation in the direction of the wall shear stress because while OSI is a ratio, it measures the flow reversal. Its values ranges from 0 to 0.5. A value of 0 basically means, which is shown by the blue color, shows the flow is unidirectional. Whereas a ratio of 0.5 indicates that the flow has completely reversed during the cardiac cycle, during one cardiac cycle. WS's vector direction variation is, on the other hand, a quantitative variable. It measures the exact degree of change. Its values are given in degrees, and it can range from 0 to 360 or even more, even till 720 degrees if the flow is too turbulent. Coming to the applications of CFD, a paper published by Dr. Sasaki Kento in 2025 described the parent artery radiation sign. The challenge was a lot of these unruptured aneurysms have an intraoperative rupture risk of 3 to 50%. These are often caused at the neck or because of wall thinning or are caused by microaneurysms that are not clearly defined on the preoperative DSA or the CT angio. So the parent artery radiation sign encompasses three parameters that will be discussed in the next slide. It demonstrated a high predictive accuracy in middle cerebral artery aneurysms with an 89% sensitivity and 78% specificity of identifying preoperative microaneurysms. So these helped in better surgical clipping because it made the surgeon aware of encountering a microaneurysm and their location. This slide shows the intraoperative, just a second. So the three parameters that were included in the parent artery radiation sign were the streamline collisions, radial dispersion of WSS vectors, and the increased wall pressure. This point shows these are the streamlines that are coming. At this point, we see that the streamlines are directly impinging on the wall, suggestive of flow impingement. This point on the WSS vectors shows that I don't think it's clear in this magnification. Basically, the directional vectors are all diverging from a single point, and this area of red color shows increased area of wall pressure. On the 3D reconstruction of the CT angio and the DSA, this microaneurysm was not visible. However, these changes were suggestive of a microaneurysm, which was identified intraoperatively. This is another example which showed these streamlines diverging, suggestive of flow impingement, the WSS vectors diverging, and the third image showing the red color suggestive of increased wall pressure, and intraoperatively, this microaneurysm was identified. Another application of CFD is identifying the thin walled regions. This paper by Professor Kimura from Kobe University in 2019 described another parameter, wall shear stress vector variation, which is the directional variation, which we discussed previously. According to his findings, he observed an 89% sensitivity and 94% specificity of identifying thin wall regions by areas of low WSS vector variation. This aneurysmal color map shows, marked by the pointed arrow, the blue colored low WSS directional variation area. Intraoperatively, this was the area that was pinkish red, suggestive of a thin wall. On the other hand, this triangular red colored area in the WSS suggestive of a highly turbulent flow was identified as the area of atherosclerosis. This was one of the cases I observed in Bantane Hospital, where this area of divergent WSS vectors was identified as an area of thin walled intraoperatively. This was another case annotated by the star mark, the pinkish red area of thin walled as identified by the diverging WSS vectors. Now, this image is one of the cases which I am currently studying. This was a CFD following placement of a web device. Not a lot of literature exists on this right now, so that's what we are trying to study. So this shows a preoperative, the pre-web scan of a right MC aneurysm, 18 millimeters in size. It had this bleb of depicting high OSI. However, because of this outflow tract, we could not have completely occluded the aneurysm. So this part of the aneurysm was left unoccluded by the web device. Post-web, the angiography was done and it showed that although this bleb was left intact, the OSI significantly decreased after placement of the web device. This is the same case. This part showed a low WSS, which is often suggestive of a thin wall, but because of the anatomy, a web device could not have or a coil could not have completely occluded this aneurysm. So this was intentionally left behind so as to preserve the outflow tract. However, on follow-up, we saw that the WSS increased, suggesting a stabilization of the membrane. While these were the applications of CFDs, the presentation would be incomplete without mentioning the limitations that we encountered by doing the computational fluid dynamic. The first limitation is that a lot of conflicting evidences exist. Some papers point out that areas of lower WSS are suggestive of wall thinning, while some with more than 80% specificity show that high WSS areas are actually the areas of wall thinning. Conflicting evidence also exists regarding the oscillatory shear index. Some show that low OSI causes aneurysmal growth and rupture, while literature also exists about high oscillatory shear index causing aneurysmal growth and rupture. The second limitation of using CFD is that the patient factors cannot be calibrated. As we all know, flow is not the only thing. The patient blood parameters like the hemoglobin, the actual blood pressures of the patient, the age of the patient, the vessel wall condition, that is not factored in the CFD analysis. The third limitation is that it's a physics and mathematical based modeling. It does not completely take into account the biology of aneurysms. It assumes the blood vessels to be rigid walls, which is not the case as we have often seen in surgeries that the vessels are pulsatile. And it assumes blood to be a Newtonian fluid with a constant viscosity, which is not the case. So these are the limitations of CFD. This Journal of Neurosurgery article by Dabag showed that hemodynamic and morphological characteristics of growing cerebral aneurysm. And this is another article. These studies show that high OSI was a risk factor for aneurysmal growth and rupture. However, this article by Professor Kimura showed that low WSS directional variation and low OSI areas are seen in the areas of aneurysmal wall thinning. So while it's not a perfect science, there are multiple different factors that might be coming into play, which we have to analyze. Meng tried to answer this question in 2014, whether high WSS causes areas of wall thinning or low WSS leads to areas of wall thinning. He proposed a unifying theory. He suggested that while low WSS can trigger inflammatory cell-mediated remodeling, leading to thinner walls, high WSS areas can have mural cell-mediated destructive remodeling, which can also cause thinning of walls. Well, this is a very interesting finding, but it does not help us as surgeons or endovascular interventionists because after doing a CFD, if we find areas of high WSS and low WSS, we cannot be very sure if which one would be the area of thinning. So further work needs to be done on this. This was in the same Meng paper. He suggested that high WSS causes endothelial cell damage, increases endothelial cell turnover, causes metallomatrix protease production, extracellular matrix degradation and medial thinning, leading to thin walls. While his response to low WSS included pro-inflammatory endothelial cells that become leaky, increased reactive oxygen species, increased inflammatory cell infiltration, leading to areas of thinning. So yes, further work needs to be done. I would like to thank Professor Yoko Kato, Dr. Tanabe, Dr. Sasaki Kento, and Professor Nakahara for helping me in the study of CFD and web devices. I apologize, I could not share all the images of the web devices because, as I mentioned, I have not submitted it for publication yet. And thank you, Professor Felitti, for giving me the opportunity to present today. Thank you so much.
Thank you, Dr. Saurabh, for the wonderful presentation. So I will ask Dr. Raja to give his comments. Yeah.
Well, thank you, Saurabh, for giving us an overall overview of CFD and aneurysms. When we were in Bantane, this was one of the main things that we used to do, the software hemoscope. And during that time, the OCI was not there. The oscillatory shearing index, OSI, was not there. It was later added by Professor Kato. So you have showed very the shortcomings also regarding like how a low wall shear stress or a high wall shear stress, which is the actual cause of a aneurysm rupture. This existing controversy has not been delineated yet, and it will be still some more time to go before we actually know what is the cause. And you also showed Professor Kimura's landmark article about the, how OSI shows the thin and thick walled regions in an aneurysm. Nevertheless, it was a small study, 25 aneurysms exclusively for anterior circulation. Posterior circulation was not evaluated in that case. Nevertheless, it was a very good study. And also regarding June's study, which you are currently doing, so June has probably the largest series of web deployment in MC aneurysms, and we are looking forward to publication of this in one of the journals. So thank you very much.
Thank you, Professor Raja. Thank you for the kind words.
Do we have questions for Dr. Saurabh Gupta?
If I can. Okay. James, go ahead.
Dr. Gupta. Thank you for the amazing presentation. You're basically doing something similar. My question is to you: after you were doing the CFD analysis post the web placement, what I've noticed the biggest challenge to doing CFD after intervention is the artifacts around the vessel you want to study. I saw you even almost had to cut out the aneurysm part just to get a clear image. How have you been dealing with that? Thank you.
Yeah, thank you for your question, James. I encountered the same problem. So to do that, we have analyzed the study in 3 parts. First was the preoperative imaging. The second one was the immediate post web device deployment DSA, which still shows some significant residual filling, but the size of the aneurysm is reduced. However, for the third portion, we had to cut off the aneurysm. Initially, I faced a challenge in making the exact boundaries of that web device. But ultimately, using magnification and spending around 15-20 minutes on each cut, rotating it and comparing it with Tanabe Sensei's actual 3D representation of the web devices, I managed to make the exact replica of the vessel walls. It takes a bit time, but you can do it.
Okay, thanks.
Yes, if issue, I can also comment. So thank you, Dr. Gupta, for your nice presentation. I always enjoy hearing about CFD because actually I was the first one using the hemoscope 10 years ago at Bantane. So we also published a paper about the very, very first experience at Bantane using CFD. Mine is a comment, but I would like to know also your comment on my comment. So after working on CFD and reading many papers, I have the feeling that it is a very interesting and fascinating technique. It's a very nice example of merging different fields, in this case, a medical field, cerebrovascular field with engineering. It has great potentials, but if maybe we've all focused too early about prediction, and which is a very difficult task for brain aneurysms because probably the development and eventually the rupture of an aneurysm does not depend only on fluid dynamics, but also on other factors which CFD cannot get so far. For example, the relationship between the aneurysm wall with the surrounding structures. We miss completely this kind of relationship in our algorithms. Also, CFD, as it has been till recently, has been based on some axioms like Navier-Stokes equations that might not be the perfect ones in case of blood flow, and also on the fact that we compared blood as a Newtonian fluid when it is not a Newtonian fluid. So there are many limitations. This is the reason why I think at this stage, the best application of CFD is actually to understand the changing of the fluid flow if we do something endovascular, rather than predict rupture. Probably we will get to that point adding more factors that now we are not dominating. But at this stage, I really commend your work because I think in this specific subfield, so endovascular treatment and placing webs or flow diverters, in this kind of settings, of patient settings, CFD can actually help us understanding what's going on with the fluid flux flow when we try to diverge it or modify it through endovascular means. So very interesting, and good luck for your work.
Thank you, Professor Filetti. So yeah, this was one of the problems that we are facing. Like immediately after a web device, suppose an area shows a high OSI. Should we really go and treat that part, or should we wait? That becomes a dilemma because literature exists and we have some evidence showing that high OSI can cause a rupture. But will it actually rupture? We don't know. So that becomes a dilemma if we should go ahead and treat or wait. Because if we wait for a rupture, that would not be medico-legally correct, and ethically it would be very wrong. But science cannot progress without knowing the natural history. So yeah, that's a bit of a dilemma, which is why I have not yet submitted it yet. That's causing a bit of a problem.
Yeah, I think we are at the beginning of our path. I still remember in our publication 10 years ago, we also mentioned about the fact that low Wall Shear Stress is often associated with a thin wall of the dome, but this was not true in every case. I kind of remember we found that it happened in our experience around in 80% of cases. So how can you use these factors if your sensitivity or specificity is 80%? Of course, you cannot base your decision to treat or observe an aneurysm with a 80% chance, which is high, but you miss 20% patients. So it's a good beginning of the story, but I think we should go ahead and making it better and better. So thank you very much.
Thank you, Professor Village. Thank you.
Thank you, Alberto. Yeah, Ben. Ben?
Ben is frozen.
Yeah, Ben is frozen.
Can I give a comment?
The quick CFD lecture. I'm really interested in it. And I have a question. So which the CFD parameter can predict the recurrence of the aneurysms after endovascular treatment. So in your study, if you are you able to look into that issue?
We have a very short study period. It's just 2 years. So recurrence of in the 8 cases that we have done, we did not find any recurrence as of now. However, for in existing literature, it shows that high OSI is associated with PCOM aneurysms recanalization. A literature paper exists on that, but in our study, we were not able to study it because of the short study duration.
I see. Thank you so much. Because I think this is very interesting. But besides the CFD, and I think as we mentioned, and as Beto just said, so we have the OSI and the Wall Shear Stress test, which could predict which aneurysm is more likely to rupture, but we don't know when it will going to rupture. But because we are only studying the fluid hemodynamic only, and we are not studying the wall itself, the vessel wall itself. So that's why I think there's another role for the vessel wall imaging to come into play, so that they could supplement each other to understand with the CFD who understand the development of the aneurysms, and then for those who are very likely to rupture, and then you could also look into account to the vessel wall imaging. That's what my understanding.
Thank you for your comment. Yeah, I had read about the vessel wall morphometry, but the resources were not yet available. Yes, but definitely it can be done. It would definitely add much more to the literature.
Thank you so much. Congratulations.
Thank you so much.
And I'm happy about your stay in Fujita. Congratulations.
Oh, thank you so much.
Dr. Sir, how much is the duration for post-surgery? After how much duration did you perform CFD in cases? The last follow-up.
In our study, the topic that we are going to publish, we did it pre-imaging, immediate post-imaging, and simulated based on the 6 month or 3 month, whichever one was available. We simulated and cut off the vessel wall in the shape of the web device.
After 6 months, you are again doing
whichever imaging was available after the initial post-procedure scan. So it was 3 months in some, 6 months in some.
So the repeat angio was not done after 6 months?
So not a very long duration. In the cases which had a residual aneurysm, in the cases that had a residual bleb imaging was available in 3 months or 6 months. In some cases it was 3 months, some cases it was 6 months. So we did the CFD analysis based on that imaging. It was not fixed. It will be a case series. It's not a recommendation.
Yeah, because you need a good time follow-up.
Longer time, yeah.
Yes, because only during that. And are you monitoring the other parameters along with that? Like you mentioned that hypertension and the anticoagulation.
No, we are not. We are not.
Variables for your study, because you have to minimize the variables to justify your study, that the results that is more accurate, because you have obliterated the variables.
We are using just the OSI and the WSS vector variation and the WSS. We are using only these 3 parameters. We are not including the patient-specific parameters.
Okay, so you can take it as like a healthy criticism, because you are doing a very good study, and it's a very relevant and new study. So you can ask the professor to include those variables. If you have data, you can include those variables, and you can make uniform population, like hypertensive or taking anticoagulants, and you're getting these kind of results in hypertensive, and those patients who are taking anticoagulants, and those who are not having these kind of problems. Because you cannot, like Alberto said, you cannot rule out the outer part effect on the wall of the brain or bone or dura, but you can rule out these variables.
Yes. Thank you for your comments, Professor Ishu. But the problem we are facing is that of the 166 cases that were done, only 8 of them had a residual bleb. So including
The
too
data
many parameters in those 8 cases would be difficult.
it's not. Yeah, yeah.
We can describe, but we cannot use any statistical methods on that.
Yeah, yeah, because data is very small. Right? That is good that only 8 patients have residual. That is also good.
Yes. Thank you for your comments. Yes.
Thank you, dear Saurabh, for the wonderful presentation. So, Alberto, we can proceed with the next presentation.
Yes, sure. Do you want to introduce
Yeah,
the next speaker?
yeah. So I would like to ask Dr. James Kiuluku for the next presentation. He is working as consultant neurosurgeon from Kenya, and he is a fellow of the College of Surgeons of East Central and Southern Africa. Currently, he works at the Department of Neurosurgery at Makuni County Referral Hospital, and he is doing fellowship in Bantane Hospital, Nagoya. And his main interest is in cerebrovascular disease, particularly aneurysm and application of CFD. And today he will be talking on assessment of wall shear stress CFD in intracranial aneurysms, a comparative rupture risk study of basilar artery and internal carotid artery aneurysms. So I would like to ask Dr. James to present. Kindly unmute yourself, Dr. James. Dr. James, kindly unmute yourself.
Sorry, let me do that right now.
Yeah, you are audible. Now you can share.
Okay, hope my slides are visible.
Yes.
Thank you so much. I want to give thank you to the organizers of this webinar. I want to also say thank you to Professor Kato Sensei for the opportunity of mentorship to our speakers who have come before me. They've been amazing presentations, and I hope a good discussion will come out of this. I've been at Fujita just a few weeks. We just started our fellowship. This is one of the ideas that I presented to Professor Kato, and she thought it would be a good thing to bring it in front of the webinar so that we can get some criticism. It's a study which I want to undertake. These are the international fellows we're working with. We're 4 of us currently. Since the study topic is very similar to Gupta's, I won't go too much into this. So I will just introduce that intracranial aneurysms of the posterior circulation, especially of the basilar artery, carry a disproportionately higher rupture risk compared to aneurysms of the internal carotid. And with the ISUA and Japanese UCAS cohort, identified posterior circulation as a significant independent predictor of rupture risk. And there was a landmark study of CFD in 2024 that demonstrated while low wall shear stress was reduced, basically there was low wall shear stress in the aneurysmal dome. This is really a new frontier in terms of vascular surgery imaging. And like Professor Alberto has alluded to, maybe we should try and find more uses for it apart from prediction. But basically, I think the main reason is the catastrophic potential for subarachnoid hemorrhage for these patients. And as we can see here, case fatality rate, and we know it's about 30%. The basilar artery terminus directly receives axial flow into the aneurysmal dome, generating higher energy flow patterns. In contrast, the ICA bifurcation receives a more oblique angle. Actually, the most similar angle to the basilar terminus would be ICA PCOM junction. Probably that's where you see most of them. And so as an illustration, the frictional force generated by the velocity of blood within the vessel confers a mechanical signal to the endothelial cells. These endothelial cells need this mechanical signaling to remain healthy. And therefore, when you have low wall shear stress, especially below 1.5 cm, and this can happen either at bifurcation or curves, the process might trigger atherosclerotic processes or endothelial dysfunction. And if you look at this, these are mainly the main parameters of even the main aneurysmal itself formation. I wanted to put these images here The parts I want you to look at are the blue parts. The blue parts are areas of low wall shear stress, and as you can see, that areas of curves. They are at bifurcations, and these are the areas most prone to endothelial dysfunction. OSI as a degree of directional oscillation of the WSS itself. So you can visualize OSI as a quantification of WSS. So in essence, we are still trying to justify and study this WSS phenomena. And I think that's where the research should go to. We still don't have a standard on this issue, but in my opinion, where there is many questions, there is a lot of potential. In our case, we looked at high OSI, identifying as regions where WSS fluctuated a lot. And these are the areas which we are looking at and considering as areas of potential endothelial damage. I'll give you a few cases that I've been working on. Basically, we want to see how low wall shear stress is not specific. So we can see here, this is an ICA CFD, a huge terminal ICA aneurysm M1A1, and you can see diffusely there is low wall shear stress almost throughout this aneurysmal dome. However, this is not specific. It is hard to quantify. How do you map whether everything is a thin wall or not? So that's why OSI comes in. So once you feed this image to get your OSI, you can see a few red areas here, which would now give you an idea as to where morphologically the actual thin wall areas are. So you need both to get a clearer image. The velocities are quite interesting to look at. You can see the velocity map here. Area which is blue shows stagnation, slow velocity, high pressure, endothelial dysfunction in that point. And the pressure map here shows just diffuse elevated pressure within the aneurysm. When you look at posterior circulation, so here the WSS which I have assessed here is a WSS magnitude average. You can have the variation, velocity variation, and also the directional variation. But in terms of comparison to the OSI, you can see that in this vertebral basilar system, there's a vertebral artery here. This is a dominant vertebral artery. There was hypoplasia on the other side. So this basilar artery is only being fed by one vertebral artery. So you can see a fusiform dilatation here of this system. And with low wall shear stress, and you can see it's present throughout. However, once you apply OSI, you can see specific areas where the OSI is high. And this can help you to get a better idea about where the thin walls are. Similarly, velocity maps as well as pressure maps. The most interesting here with this pressure map is we were talking at a previous slide about the pressure indexes in the anterior and posterior system. In this system, this vessel is almost red. It's very high pressure compared to the internal carotid, which we had seen. Now, in terms of a clinical correlate, I think most of our discussion was based on this. This is an ophthalmic artery that Professor Kato Sensei clipped maybe maybe 2 weeks ago. And I'll start with pre-op. Pre-op low WSS showing at the dome. Pre-op, and here it's almost diffuse here. And then high OSI at the inferior portion. So yes, there is wall shear stress all over, but you apply your OSI, you get a more clearer image. And if we see at the clinical correlates, you can see intra-op ICG showing brightness around the same region. And eventually when the aneurysm was exposed intra-op, this is the image we were able to see. So the questions now arise. Pre-op planning and intra-op decision making, I think, are helped greatly by this form of CFD. Now, when we come back to my study, in terms of endovascular techniques, we are seeing less and less aneurysms of the posterior circulation being exposed intraoperatively, and even some in the anterior carotid systems are not being exposed. So if we are not doing this CFD and trying to see this aneurysm morphologically in the operating room to help us make decisions of clip applications, what if with all these endovascular cases we are doing, would they help us to maybe choose our micro wires better in terms of how we are cannulating these vessels, or where we let the microcatheter rest as you make your decision in terms of what next to do? Maybe we can use that to assess how we can plan even endovascular techniques. So my main endpoints are rupture risk of both systems, definitely assessing wall shear stress and OSI. My study design is as follows. We're doing a retrospective study. This is a comparative study. And to try and reduce the bias of the CFD itself, we are doing a propensity score matching technique using the nearest neighbor. So basically, we want to stratify these patients in terms of age and comorbidities. CFD does not account for age, does not account for drugs being taken, for hypertension. So we want to avoid the point where we are comparing a 19-year-old baseball player with a connective tissue disease, with an aneurysm at the basilar tip, against a 90-year-old lady who's relatively inactive. And if we compare these two things, I think we get a lot of bias between them. Obviously, we are doing this study here at Bantane Hospital over a period of 3 years. Data will be acquired via CTA, neuroimaging, especially generating via hemoscope, and clinical records. Our inclusion criteria, one of the things that has really been stressing me is getting clear 3D images available to construct the CFD model. You realize even with a little miscalculation about where you cut the vessel, it changes your parameters. So that's one of the hardest things. Sample size has been determined via one of the largest meta-analysis done on CFD, to try and have maybe 10, 20 patients on each arm. Analysis will be done as follows, and our expected results are the basilar tip aneurysms are expected to show significantly higher peak inflow velocities with overall lower mean wall shear stress and a higher OSI. In terms of the anterior carotid, internal carotid system, particular in terms of their breakdowns, the PCOM ICA junction, probably what will show us the lowest WSS values. Okay. And therefore, in conclusion, computational flow dynamics can be an important predictor of aneurysm risk, but also of morphology, as well as helping us to guide surgical treatment, and especially in this new era of endovascular techniques. Thank you.
Thank you, Dr. James, for the wonderful presentation. So I would like to ask Dr. Raja to give his valuable comments.
Well, James, thank you very much for showing us your study design and your methodology. I would like to ask, why did you choose both posterior and anterior circulation aneurysms? You could have stuck to only posterior ones in your case. Why did you include ICA into it?
Because I found very few studies that did an actual comparison between these two systems. It is true the Basilar system is one that has been least studied. So it's a good idea, but I decided to do a comparative study.
Because the risk of ruptures are different in both anterior and circulation. So whether there is any logic in comparing CFDs with already known risk.
Yes. So the idea was to see if CFD can be can work for you as an independent predictor.
Okay, thank you. This issue.
Yeah. So the house is open for the discussion. Do you have some comments for?
you. Can I give a comment, please?
Yeah, Thomas, please.
Thank you for Dr. Gupta and James for presenting the CFD topics. Actually, myself, I don't practicing CFD, and but based on my observation of reading and attending presentation of CFD, I think the main pitfall in this method is the software dependency. So different software will give different results. And also I noticed that the first one using this technique is engineering because of the airplane design and also F1. So I think if we comparing it to medicine, we have to take measure of the variable of endothelial function, the thickness of the wall, and not just the factoring. So I think we have to do more regarding the CFD technique. Thank you.
Yeah, thank you, Dr. Thomas. Do you want to say something, James?
It is quite true. Also, there is a bit of user dependency to it, because it's really up to how good you are to cut the vessels. So, my idea would be if the CT technology would also, so CFD wants all these technologies to advance almost at the same time. If we were to get to a really good CFD that could give you up until cortical vessel 3D reconstruction, it would make it way more accurate. But yes, the concerns are valid. But I think it's a very interesting area to look into.
Yeah, for additional comment that I think if you compare in endovascular era, you can probably using CFD you can choose between if one aneurysm is better for using flow diverter or flow diverter with coils, or what's called flow disruptor, or just balloon and coil. So different technique, and you measure the CFD. Probably there will be some result and a discussion about which one or technique or instruments is more beneficial to the patient.
Yes, thank you so much, Thomas. That's a very important issue. Actually, one of my first ideas was to use CFD to check post-endovascular treatment of these patients. What I struggled with is elimination of the artifact while generating the CFD, but I think it's one of the major applications that we should be looking at. So maybe Dr. Gupta has encouraged me to give it another try. So thank you.
Thank you, Dr. James. Do you have any more comments? Professor Kato, do you want to say something?
So the three speaks that it is very wonderful. The Akutsu sensei taught us so many the various approach and also the type of the aneurysm. So thank you so much. And also that about CFD, of course, Alberto is the first fellow that he studied almost 10 years back. And I think now it's endovascular the era. So and also our institute is most of the case treated by the FD and also the web. So very seldom to see the recurrence. The Gupta shows us one case after the web placement. There is a small pouch is remnant. So that part is he wanted to clarify that it is the thin wall or thick wall, because we wanted to decide how fast to treat the remnant part, the pouch. But it's quite difficult. He already mentioned. And also I mentioned many times that the bleb, it seems very thin wall but sometimes it becomes very thick. The time to time, the beginning is very thin, but maybe after some times it becomes a very thick bleb. So if the patient has a bleb, is not so dangerous sometimes. And also vessel wall image is still very difficult to how we can read, because sometimes the aneurysm itself is very small, and the judge is very, very difficult. I think, yeah, we studied several cases. Still, I have some questions. And also, in Japan is almost 90% is unruptured case. So the patient just want to know my aneurysm will be ruptured in the future or not. Only that they focus on. So I think in that means the CFD is very simple and easy to create before the treatment. So maybe we can tell the patient with a large type and with pleb, it would be ruptured or not. Maybe we can give the patient some suggestion. I think that today's two young doctors regarding the safety was so nice. Thank you very much. It was very worthwhile to listening. Thank you, Albert and Ishu.
Thank you, Professor. Yeah,
Thank you.
Please.
Yeah, thank you, Professor Kato. Thank you, Ishu, for this very nice discussion about CFD. We had two great lectures. I also, from my side, want to thank all the three speakers. It was really, really informative in two complex fields like endonasal transfemoral surgery and also CFD. Thank you, Raja, for your comments, always precious. You are like a book. You are like many books because you have many knowledge. And thank you, Thomas, for helping our discussion as well. And I think we can close this webinar. Thank you all, and I will meet you again 1 month later for the next webinar hosted by the Alumni Association. But I want to ask Dr. James, because actually there is something that captured my attention. Behind you, there is a flyer with a very famous Italian painting, which is Mona Lisa. What is that flyer about? Maybe Professor Kato can help.
That is a endoscopic, microvascular decompression, I think.
Oh, and why Mona Lisa? Why Mona Lisa?
I don't know. The present.
We should ask the organizers. It's a very nice flyer.
Yes, it's beautiful. Yes.
Yeah.
Always I watch the flyer.
Yeah, it's very, very evident. It captured my attention.
Thank you so much.
Okay. Thank you.
Thank you, Raja.
Thank you, Sensei. So let me let you know that the WFNS ACNS webinar is going to be live in another 15 minutes. You all are welcome to join.
Oh, yes. And also let me take the chance to show actually a flyer which I was required. So maybe I can share my screen, as there will be the Asian Congress in August, and this is the webinar by the Alumni Association. Please remember that on August 1st, there will be the Fujita Health University alumni cocktail reception just before the official dinner of the Congress. So this is the flyer. We will share the flyer, of course, with all the alumni and all the fellows, but this is just to remind you about this event. And the day after, August 2nd, we will have the alumni session within the Congress, so please don't miss it. Unfortunately, I will miss the cocktail reception because I will arrive very early in the morning on August 2nd, but Professor Kato will be there for the cocktail, so please join and have fun.
Please join everybody. Thank you.
Thank you.
Okay.
Bye-bye. See you.
Can I join?
Bye.